I request Girija Vaidyanathan, who was till now the Secretary Health, and she has rich experience. She has put in 7 years. Something like that, but 7 years as in the health sector in Tamil Nadu, and has done her PhD from IIT on what was it, Girija? What was on equity in health? And I requested her to send a thesis to me and to all of you. Put it on the net. Yes. But she's extremely bright. That's too much.
Good afternoon, everyone. After that introduction, it's difficult to say anything really. I must start with, out of the 10 minutes given to me, 1 minute on a series of apologies. I'm a last minute entrant. As Madam said, I was till last week Health Secretary Tamil Nadu, and I had refused to come because I didn't have time. Subsequently, the government did me a favor by transferring me, and therefore I am where I'm really here to learn. So when I wrote to Dr. Devadathan, he said, why don't you make a presentation? I was really thinking that it's been nice to sit in the audience, but having a few slides to share, being a practitioner, I just thought I would put those forward. The second apology is that till now UHC was for me just a term. I mean, as in the last 1.5 years when I was Health Secretary in this stint, there was really no time to look through the report even carefully. So I have to apologize that most of what I'm talking is read over the last 4-5 days in detail. So it's for those who worked on the committee or those here who definitely know more than me, I am putting together what came to my mind and what I'd like to share with this audience so that we can go back and think about this from a policy, from an actual, as Dr. Devadathan put it, rather simple-minded policymaker's perspective. So it's correct. The fact is that we don't have time to go through the detail. We really have to think of it as what do I do next if this is what is presented to me next. Now, this is a very simple slide because I think we have been hearing about UHC since the morning. I think what we all agree on, or what I don't think we need to have much of discussion about, especially after such illustrious presentations before mine, both Professor Ann Mills, who I was also really happy to hear because she was one of my reviewers of my thesis. So it's been a great pleasure to meet her in person. And Professor Geeta Sen, who I always hold in very great admiration, as well as Madam Sujata, who has been a kind of role model for me. So it's, for me, I'm on a panel where I feel a little bit unfit. Then the next one is recommendations on financing. I think Professor Mills and Geeta explained quite in detail, and I think there are not many people who disagree with what is said there. Then need for strengthening of public health care. Again, I'll go through it in a few more slides, but not much to say there either. Need for regulation of private sector. I think as somebody said, we are starting at the rock bottom. I think Geeta said we have done nothing so far. Yes, we definitely need to do it. To increase availability of drugs and vaccines domestically, yes, definitely. And to increase the community voice, because as all of us who have worked in the health sector see that there is no future forward unless all these things are done. Now on financing, as I said, I don't have to go through these. These were all points mentioned. And increase in public financing percentage to be shared between state and central governments. No user charges. You'll be happy to know Tamil Nadu has had no user charges or very, very minimal user charges. Even through the 90s era, which was explained in the morning, we never fell in that line, and we have always been user-free charges. General taxation as the main source with some supplementation. And 70% to be spent on primary healthcare, but primary healthcare defined a little broader than we normally look at it, including promotive and preventive care and some other aspects which we need to consciously think about. And as regards strengthening public sector, to be, I mean, this word I found in some of the literature, the bedrock. I sort of liked it, so I thought I have to use it the next time I talk to a captive audience. So before lunch, you are a captive audience. So the public sector to be the bedrock of the program. Required health services to be contracted in. This is the, I didn't put the quotation marks there. This is the term used time and again in the report. I mean, I'm not very sure the literature whether what is contracted in and contracted out. Even when I was reading this for my research work, it was always a doubt for me. But through the public sector and emphasize public health management cadres and ensure a good procurement and logistics system for supply of good quality generic drugs through public health facilities. Now, number 2 is a bit doubtful from what the point is contracted in through the public sector. In Professor Geeta Sen's presentation, she has said that. But I'll come to that when I talk about what is not so clear. I thought at least that these were very self-evident. And then, so the next thing is, where did I feel it was doubtful when I read it the first time? And I think Dr. Devadasan spoke about this, to define the package. I mean, it's easy to say define an essential health package. And we have, Dr. Bruno mentioned it so many times that we've rediscovered this package many times. What is this package? We have a lot of vertical programs. How do we integrate them? Those of us who have worked in the health sector know it's easier said than done. Second, setting up the standard treatment guidelines and protocols. Now, these again, the countrywide, statewide, we have talked about these at many levels, but we need, if we are going to talk about contracting, capitation, all these terms that are going to come in as we build this system, unless we have clear guidelines for these treatment protocols and guidelines, I don't think this would be possible. Then training of existing medical and paramedical staff in the public sector. Wherever I'm talking about this, I'm talking about the public sector largely, because I think many of you who are practitioners and researchers will also understand that most of them are very unilinear. They will do whatever is given to them. The pharmacist will do pharmacy and the lab technician will do lab technician. And the worst case is the medical officer, who's mostly a very young graduate, will go and do outpatient work. So we really have to do a lot of I mean, this term has been used in the 11th plan report. It's been used in the NRHM framework document. We've called it multi-skilling, but I also call it, we need to do a lot of identification of gaps and training. Then building capacity for contracting in, again mentioned by my previous speakers. This is one of the toughest, I'm talking from the position of a state like Tamil Nadu, where actually we have done a bit of work on this. As I go on, I will explain what we have struggled with in contracting in. As everyone knows, the old PPP models were all, not great successes from my point of view, because unless they were not-for-profit providers, where actually we worked on very grey areas, there were really no contracts. We worked on good faith. That the examples would be the family planning program, the blindness control program. Those have worked, and that is what we tout as great successes of our PPP program. But fundamentally, contracting for health with public money and good quality and monitoring good quality service provision has not been really achieved. I'm making a very grand sweeping statement, but we'll leave that for the discussion. The last one is urban areas. I think I speak from, as I said, a state perspective, and that too of a state which is doing relatively well. The rural areas with some form of rudimentary primary healthcare system, or there is something we can talk about. The chart he drew, the web he drew will reach somewhere. In the urban areas, the concept of even rudimentary frameworks are missing. So you will have to rewrite, and as I was just talking in the morning, expectations of even the urban poor. And I use this term lightly because who is poor in our country? Or to rephrase it, who is not poor in our country? Because when we talk about out-of-pocket, medical costs are so high that it can impoverish people. To a great portion of our population stands to be impoverished by the kind of costs that they are facing in the medical sector. So this urban area is a challenge which has not been consciously mentioned anywhere. And I feel that as a state, this would be a major challenge where a lot of work needs to be done. Where are we unclear? Now, that was where I think we know what we're doing, but we have to do it. Here, I'm unclear. Now, the relative roles of public and private sector, I think Dr. Geeta, when she mentioned it, said that it would be contracted through the public sector. The public sector should be strengthened first before we go out to contract. Now, that's a clear statement, but from the report, I was not able to get this, and we have done earlier work. There are people in the audience here. We have worked in a district called Pudukkottai, where we tried to find out where the private sector existed. And we found that the private sector existed where the public sector existed. And the second problem, which has been mentioned in many of the literature, is that most of our public doctors are given permission to practice, and it will be difficult to wish that away with one wave. And when they do that, and we have watched that in every program we have run where there's a public-private interface, they tend to send out the customer from the public sector into their own profit-making private sector. And I leave this as an open. Then the second one is, how is this provider-purchaser split to be achieved? Now, the term used is networks for managed care. This is the term within the report. But as far as I was concerned, we were the first state to set up the Tamil Nadu Medical Services Corporation. That was a vision of one of our senior bureaucrats. I was, before I got transferred, I was busy trying to get myself a vision. Now, it never came, and now I'm trying to do something else. So the fact is, how do you create this organization at the district level, which will purchase care? Now, why I say this is we have struggled with this, comes in the last slide, which is the next slide. We did try this when between our two, the Turbo RSBY program that we are running, we got caught in a political gap between one government and another government where we were contracting the new insurance provider. In between, we actually tried to run it ourselves. So in a sense, we actually contracted private sector directly by government, and we openly did it. We had most of the structures of the previous insurance program, though of course the services were slightly different, but they were simpler because we were actually contracting inpatient services, and we had most of the structures of the earlier program, and we really found it tough. And I can only tell you that everything went all right because it was also, there's a question asked of what does the insurance company do? I'll leave this thought with you again. I hope, though it's being filmed, I'm talking purely in a private capacity and I cannot be quoted as a government servant. The fact is, when there is an insurance provider in between, there are certain forces that cannot operate. Right now we have a public sector insurance company. We say things like, no, this disease cannot be covered. No, this quality rating cannot be given to that hospital because United India says so. I'm sure Dr. Sudarshan will understand what I'm saying, and so will Madan Gopal. And I'm sure the others in this audience will understand. So we actually use the insurance agency as a buffer. And that's an interesting role that we need to keep there. And this gatekeeping role of primary health care and was mentioned in terms of both, as Dr. Mill said, the gatekeeping role or the supplementary payment role. Currently, we have nothing. Wherever we have tried to push people through the primary healthcare system, even for our insurance scheme, we tried to say that it should be referred through the public health system. We failed miserably and we got big political knocks on our head. Of course, access also was distinctly reduced. We have to admit that it was not just a political statement. So how do we, if we are going to have fund holding at some, within a primary facility or through a primary care system, which is when this will actually be different from what we are doing today, how do we make this, how do we strengthen this and make it politically completely saleable? And the last one, this point is very, very important to me. Madam said I've been secretary for, and I've been in health sector for about 7-8 years. I have been in NRHM for 3.5 years. I was mission director NRHM. I believe that whatever, I don't think it's a blemishless program or it's a great program, but I believe that we made a lot of progress over the last few years with NRHM. And I believe that whatever we are saying, it should not be, India has a tendency to throw out the wine with the bottle. It's not only old wine and new bottle. The entire wine goes and we start doing the whole process again. So I really want to build this into what we're doing now. Yes, I think we must move towards a complete model instead of a fragmented model. But I do not think we should say that that was bad. Okay, out with the old and in with the new, and here we all start over again. Now, more clarity, role of Ayush community health workers. What about nurse practitioners? The definition given there of 75% of the outpatient work will have to be contracted in. I don't understand all this. There's the Nashik experience where they found that most of the better private practitioners wouldn't join programs anyway. How do we get all these people? And how do drugs get distributed when we contract private providers? Secondary and tertiary care, I have to share with you what happened with us. Our first program was called Kalaignar Kaappeetu Thittam. It was reasonably successful if you want to just see it as an insurance program. We spent a huge amount of money. We are a luxurious state. We could afford to do that. But the end of it, only 1% of the claim amount went to government facilities. In the second round, we found that we could not change the procedures because they had already been agreed on certain procedures. We also found that government hospitals, which are also our teaching hospitals, started not getting any procedures for hernias and ENT care and certain things which we had by mistake included into the first list. Now when it came to the second round, we did what we do in our country very well. We reserved 20% of the programs for only government institutions. There was a lot of complaining from our own doctors, from a little bit of the public, some of the public representatives, etc. But this reservation has worked wonderfully. Now 30% of our claims are going to government hospitals. And we are back to doing those services there. The doctors are getting the additional money. We have yet to see how successfully we use that money. But in all international parlance, this is bad. You know, it's bad economics, it's bad thing to reserve. When they asked us whether we will take RSBY for our state, we said, would you allow us to reserve some of the procedures for public sector? They said, no, it is outside the philosophy of this program. So I'm just throwing open to you that we did the wrong thing and it seems to be at least temporarily working.
Outcome.
And this is the last slide. What is the way forward for Tamil Nadu? We would like to take this forward. We would like to develop a district-specific model where utilization of public health facilities is already very high, Dharmapuri or Tiruvannamalai, where there's hardly any private sector. We'd like to identify the basic health package, and we would like to use the CMCHIS cards as primary identifiers, and we would like to see whether we can actually develop a model and methodology for the contracting in of services and regulation of the private sector use. Now, this is where, this is not my official work now, but I would really like to see this happen, and I hope that this conference is, as I said, it's really nice to be here and meet all of you. And when another 2 years later, when we all meet, I hope that we will be able to submit a paper on how successfully we have been able to take this model forward. Thank you.
Thank you, Girija. I think we should resolve to have her back as the health secretary in Tamil Nadu.
Can't say that very loudly.
Can't do it, say it loudly.